Good morning and welcome, and I hope I will present a few challenges and a few things that you can think about in future today. I will be talking about the nutritional management of the consequences of chronic kidney disease. Now, in 406 before Christ, Hippocrates already said, he was the father of medicine, let food be your medicine and medicine be your food. And the time is ticking on this. The incidence and prevalence, as Heather said, of kidney disease worldwide is escalating, and this is just a slide to show you how it's escalating in the US. Protein energy wasting is a big topic in kidney disease these days. It is defined as a syndrome of adverse changes in nutrition and body composition. It's highly prevalent in chronic kidney disease, especially in your population on dialysis, and it carries a very high morbidity and mortality. Chronic kidney disease per se results in systemic inflammation, as well as in nutritional disorders, which all contribute to catabolism, a higher morbidity and a higher mortality. There's been many words used to describe this loss of body weight and muscle in the kidney patients, and it went from malnutrition to malnutrition, inflammatory, arteriosclerosis syndrome, so some of them were very long words. And then the ISRM decided to come up with a standard definition, and that is that protein energy wasting is now defined as an abnormality of low levels or excessive losses of body protein and energy reserves. Again, just a slide to show that there's a very high prevalence of protein energy wasting. It also depends, of course, on the method used to assess this. But in general, it starts sort of mid-stage 2 and it gets worse, where the highest prevalence is in CKD5. And you can also see on the bottom part of the graph where how your appetite at the same time decreases. The bottom line is it's common. It causes a deterioration in quality of life. It decreases short-term survival, and it's a powerful predictor of outcomes. But there are still some controversies that are not completely resolved. We know it's got an excellent prognostic significance, so that's not a problem. If you lose a lot of weight as a kidney patient, mortality and morbidity will go up. But there's still a lot of debate on the management. And the biggest question is, if we improve the protein energy wasting or is able to prevent it, are we going to influence clinical outcomes? Does it matter, in other words? And the last one that we're not going to refer to today at all is the role of overnutrition and the so-called obesity paradox, which has been coming up in quite a few disease states. The etiology or mechanisms. Now, we all thought and knew that pure undernutrition is prevalent in this population. They've got anorexia, they don't feel like eating, and they lose weight. That would be your pure undernutrition. But then a lot of them lose more weight than what we thought. Why would this happen? And that is because there's a lot of factors inherent to the kidney disease per se that plays as big a role as undernutrition. And that's a very nice summary slide that shows you all the players at this stage, and I'm sure this will become more and more, that plays a role in protein energy wasting. And the interesting thing is, I don't know if you can see that, is the interrelationship between some of them. We have it there as well. And that I will show you a couple of slides to show you exactly what that means. What is the consequences of protein energy wasting? It causes deregulation of certain mechanisms and activation of your compensatory mechanisms. That results that will impact on various organ systems, right from the immune system to your gut. You will get poor adaptation to the acute phase response and an increase in overall mortality. What we also need to remember is that the comorbidities quite often often share a similar catabolic milieu, or they can further impact on the protein energy wasting. If we take a diabetic, for instance, who has gastroparesis, you can understand how that will contribute further to weight loss in these patients. And they've got a common etiological mechanism. But sometimes there are questions whether protein energy wasting is the consequence of something, or is it cause? Chronic kidney disease, metabolic bone disease is a very interesting example here. We know that protein energy wasting can cause the bone disease, but can it be the other way around? Protein energy wasting will result in weight loss, it will give inflammation and physical inactivity, which will give you bone loss. So that way there's no problem. But if you've got CKD MBD, you will also have protein loss and anorexia, which will both contribute to hypovitaminosis D. And hypovitaminosis D plus a decrease in Cloto and FGF23, which is now becoming an extremely important player in various components of what goes wrong in chronic kidney disease. You will end up with an increase in parathyroid hormone. And vitamin D and parathyroid hormone has for a long period of time been implicated as contributors in protein energy wasting. Now, if you take vitamin D and you start supplementing it, what do we find? We find an increase in muscle mass or size and muscle strength, just by giving vitamin D. Increase or improvement in the markers of bone turnover and muscle metabolism, and or in serum albumin. So there's also a positive association between 25-hydroxyvitamin D and testosterone, which suggests another mechanism. From this, it's quite clear that if the patient has chronic kidney disease-related bone disease, they can become malnourished because of the changes in the mechanisms. Diagnosis. It is a single syndrome with a whole lot of causes that gives you undernourishment as well as hypercatabolism. And these two factors converge to give us protein energy wasting. It has a multifactorial origin, so we need good criteria to diagnose it and a comprehensive way to treat it. There's various methods which are included in your books but not on the slides, and the slides that I've put in your books is a lot more extensive than the ones that you see here. But there's a lot of methods that's been used over time to assess nutritional status in these patients. But most of them have some or other shortcoming. The ISARM then went and set up criteria in 4 categories and said you need to satisfy a criteria in each at 3 out of the 4 categories, at least 1 in each category, done more than once, at least 2 weeks apart. And it looks quite good. It looks like, this could work. However, Lining then in 2011 tested this suggestion and found that in their patients, if they didn't find anyone with malnutrition if it's 3 out of 4. If they change it to 2 out of 4 categories, it was protein energy malnutrition in 17% of the patients. If they compared it to what they get with something like SGA, it was extremely low because SGA showed a 65% prevalence. So at this stage, I wouldn't recommend that you use this as a sole method to assess your patient because there's no studies, no prospective studies that has tested this specific tool yet. It's a suggestion, but it hasn't been completely tested. With our nutritional management, you can see that it's extremely important in these patients to screen and assess, to design a nutrition care plan, and we should consider the unique needs of the specific patient in terms of energy and protein, as well as the sources of other nutrients. And I will qualify that just now when we talk about phosphate and fiber and things like that. And also consider the etiology. Try to find out what factors in this specific patient played a role and how can I address it to improve the situation. Just something to remember is that the latest KDIGO guidelines actually increased the protein recommendation in non-dialysis dependent patients to 0.8 grams per kilo. Some organizations still recommend the 0.6. But they suggested 0.8. And this whole PEW's problem that we're sitting with is probably contributed to this decision. The hope is that we know that if we restrict protein, we will restrict urea and other products which cause appetite suppressing and weight loss. However, a lot of literature previously said that if you want to delay the progression of chronic kidney disease, you need a low protein diet, and that has now become a controversy. Whether it's protein per se that actually plays a role there. And that's part of the reason why we now get 0.8, which hopefully will help with less malnutrition. I see a lot of elderly patients. And if you go to a restriction at 0.6 grams per kilo, I mean, there is just such sarcopenia, there will be nothing left. And they cannot afford the amino acids and keto acids and all the fancy stuff. So hopefully, especially in that population and diabetics, this will help. And hopefully they will also adhere better to the guidelines. Because normally to the very strict guidelines, we know that adherence wasn't that great. The second thing to consider when we're looking at protein energy wasting is the anorexia and the undernutrition. And most studies in maintenance hemodialysis and CP patients actually show that the patients never meet their requirements. And often, even in my non-dialysis dependent kidney patients, they don't meet their requirements. Okay, so it's not like the requirement is that high, they just don't meet it. Plus, during dialysis, your resting energy expenditure increased by 12 to 20% during the procedure. And there was even studies that showed that it could last for a period after the procedure. Also remember to look at the comorbidities, how it will impact on your intake or absorption or metabolism. Protein supplementation, it is important to optimize the protein intake through supplementation, and it's been proven to be effective. We do have acute peaks in metabolism during and immediately after dialysis, and it could contribute as much as 1 to 3 kilogram muscle loss per year. That's massive. And there is some indication that intradialytic TPN will be beneficial there. Also quite interesting is that the sources of protein in these patients, just like in the critically ill patients, may become quite important. There's not sufficient studies on that yet. But whey protein, we know, has a positive influence on body composition, mainly because of the high leucine content. Soy protein, on the other hand, doesn't have such an anabolic effect, but it contains isoflavones, which is anti-inflammatory and may also contribute to preventing protein energy wasting. There was a trial done, and it's one of the bigger trials. It's about 46 patients in the trial. They supplemented them with either soy, whey, or placebo, and you can see very clearly IL-6 levels, sign of inflammation decreased in all of them. CRP only reduced when all the groups were put together. Gait speed and shuttle walk, that's how good they can actually walk, improved. And ALP, a marker of bone turnover, also improved on all of them. So actually, you can get a little bit of benefit with this one more than the other one, but that actually cancels out. So whatever you do, it doesn't matter, just supplement the patient. As I said in the beginning, the biggest problem at this stage is if we improve the biochemical parameters, are we going to improve the outcomes? There's a little bit more data in maintenance hemodialysis, and yes, there are some data that shows if you supplement, it has a favorable impact on survival. But the bigger problem is that we don't know what the effect will be in non-dialysis dependent patients, because there's just not any proper prospective randomized trials. That was just an algorithm. I think I've included more than one in your books. That show you how you can go through the assessment of your patient and be guided by a few factors. And the last slide is just a summary of the concepts. And the very last one, yeah, I thought was a very nice slide, because it actually just shows you how all of this is interrelated. Right, phosphate. I think for a lot of us in practice, that is one of the big headaches. Chronic kidney disease results in the accumulation of a lot of waste products, amongst others, phosphate. Initially, there's compensatory mechanisms, which helps you to maintain your phosphate in normal ranges up to about CKD 5 or end-stage renal failure. Why are we worried about this? Hyperphosphatemia can result in renal bone disease. And now we also know that it plays a big role in cardiovascular morbidity or mortality. And it plays a role in the progression of kidney disease, probably bigger than protein. Normally, about 70 to 90% of phosphate will be filtered by the glomeruli and reabsorbed by the tubular cells. And it's controlled by parathyroid hormone and FGF23. This FGF23 is quite interesting. The progressive rise in FGF23 levels with deterioration of your kidney function results in a progressive increase in risk of death and cardiovascular damage. So it's possible that if we are able to reduce phosphate uptake in the gut, we can improve FGF23 and reduce all those complications. Not all phosphate is equal. Your inorganic phosphate, which is the one isoform that you will find in nature, is extremely absorbable at about 90%. And that's mainly food additives. At the bottom is your organic ones, which go between 40 and 60%, with your plant proteins the lowest. Fruit and vegetables contain most of them contain minimal amounts of phosphate. On the other hand, seeds, nuts and legumes contain a sizable amount of phosphate. And traditionally, we've excluded this from the diet of kidney patients. But most plant forms is in the form of phytic acid or phytate. And humans don't have the enzyme to break it down. So, the bioavailability of the phosphate in plant foods is a lot lower than that in animal foods. Having said that, remember, I'm just trying to illustrate the point about phosphate. Don't forget that those seeds and nuts and legumes is also very high in potassium. So all of this becomes null and void if your patient has a high potassium as well. Yeast-based phytates in whole grains makes the phosphate content or absorbability of leaven bread much higher than that of cereals and flatbreads. So choosing the type of bread may have an impact on how much phosphate is absorbed. And what we don't know at this stage is exactly what the effect is of probiotics on the breakdown of the phytates. There are some studies that show that if we increase the protein from plant forms in the CKD patients, we decrease the bioavailability of phosphate and we decrease FGF23 levels, which is exactly what we want to achieve. On a more practical level, this phosphate is quite often a main component in a lot of additives and preservatives. Common foods is from spreadable cheeses to dark cool drinks to bakery products, anything that's processed will probably have added inorganic phosphate. And that was just a list to show you all the various salts that they use and all the names, because quite often the phosphate content is not listed on a label. So you need to teach the patient all these salts so that they know about them when they read the labels. Your additives are inorganic phosphate. They are salts and they are more readily dissociated and absorbed in the gastrointestinal tract. And a lot of them will be absorbed, more than 90%. So it's a major health concern, the fact that there is such a lot of foods with added phosphate. And some foods may contain both. If you take ham, that will have the natural meat phosphate, organic and inorganic phosphate. So the phosphate burden from inorganic phosphate is extremely high. It's out of proportion high to organic phosphate in the diet in modern culture. And processed foods are not just high in phosphate, but because it's inorganic, it's also better absorbed. So that's the last thing we actually want. Colas are very high in phosphoric acid. Your clear cool drinks and most of your teas are a little bit lower. But remember, in your liquids, it's generally exclusively from additives. It's not bound to protein. So, and it's in a liquid form. Most things are better absorbed from a liquid form. So this is probably the most readily absorbable form of phosphate that you can get, is in liquids. And also just an interesting list, American data of the phosphate content of cool drinks. Cheeses. Now we know dairy products is very high in phosphate. But maybe we can help our patients a little bit and vary the diet a little bit more if we look at the phosphate content of the different cheeses. And it can vary in 50 grams from less than 100 milligrams in cheese to in brie cheese up to 500 milligrams in spreadable cheeses. And that's just German data, where right at the top you've got the brie, right at the bottom you've got cheese spread. The consequences of a high phosphate is that we get a high calcium phosphate product. We know it will lead to chronic kidney disease-related bone disease, but it will also give you vascular complications because you will get vessel calcification, and that will increase your mortality. Now I want to show you an interesting dilemma that you can end up in. The KDOQI guidelines say about 800 to 1,000 milligrams of phosphate maximum. But then on the other side, they tell me if I have a hemodialysis patient, I should give them about 1.2, maybe 1.5 grams per kilo of protein. And even in non-dialysis dependent patients, we now say we want to give 0.8. Now what about the patient with protein energy malnutrition? Protein energy wasting. We know there's poor survival, but the patient also has a high phosphate. So what are you going to choose? You're going to prevent the protein energy wasting, or you're going to give them a low phosphate diet to treat the phosphate and prevent those complications? Any volunteers? Ah, you're all scared. It's not that difficult, actually. You need to remember the bioavailability of the sources. So if you've got a malnourished patient, obviously you have to concentrate it on the sources that has the lowest available phosphate. Enhanced protein products is the worst. Plus, to use phosphate in milligrams to protein in grams ratio may be a much better way to let these patients calculate and work out their daily phosphorus intake. So the diet should be all over fairly low in phosphate. We need to encourage a good mix of animal and plant proteins. That's high in phytic acid. Limit processed foods. Use cooking modalities that help to get rid of phosphate, like boiling. Use selective vitamin D activators to reduce intestinal absorption. Diligent use of phosphate binders with a lower pill burden. I remember when I was working in the renal unit at Tigerberg many moons ago, we'd give the patient like 10 tetralax because that's all we had. Now, do that 3 times a day with each meal. Well, I also wouldn't do it after a while. So you need something that has a lower pill burden. And then use user-friendly education tools about phosphate units to make it easier on the patient. The next point is the uremic toxins. Now, we've all known for many years that the colon reabsorbs nutrients, get rid of wastes, reabsorbs some water. But these days, the colon is actually becoming a lot more important in our bodies than we thought before. It has a lot of extra, we now know about a lot of extra duties that it performs, and amongst others, it is a source of uremic toxins. But what are uremic toxins? Uremic toxins are solutes with an adverse biological activity. They are retained not only as a consequence of chronic kidney disease, but they contribute to the progression as well. They protein bound, which makes them quite big, and that makes it very difficult to get rid of them with dialysis. And that is just to show you the hundreds that's been identified, and the list is longer than that. That list is already a bit old. Okay? The 2 important ones is p-cresol and endoxyl sulfate. Protein peptide chains is broken down by hydrolysis into small peptides and amino acids. That goes to the colon, where the intestinal flora will work on it to give you either short-chain fatty acids or potentially toxic metabolites like your amines, thiols, etc., or it can be used for growth. Tyrosine and phenylalanine will give you your phenols, and you can see in that case the bacteria that actually does that has been well described. Tryptophan will go to the indoles, and then your lysine and ornithine will end up as amines. You also go to the liver for detoxification, and that's when your phenols will be conjugated to a sulfate. Your indoles will go to indoxyl sulfate, and your amines will go both to the liver as well as to the colon, where they'll be detoxified to various breakdown forms. This slide shows you that those 2 uremic toxins end up giving you the same problems. The targets of your uremic toxins, we know that one of the targets is the kidney, and that indole sulfate gives you an increase in your TGF-1, your pro-inflammatory cytokines. It reduces SO scavenging, and you end up with a lot more free radical activity that will worsen your kidney failure. But similar processes is happening in other organs, and that we didn't know for many years, on the bone, in the lungs, and the heart, and now also protein energy wasting. I actually added that part of the protein energy wasting to an original graph. So how do they contribute to cardiovascular disease? They actually cause endothelial dysfunction, and is independently associated with mortality. In bone disease, they cause PTH resistance, and especially indoxyl sulfate is one of the big factors that cause skeletal resistance to PTH. How can we fix this? Oopsie. Thanks. We can use fermentable carbohydrates. From a physiological point, we can excrete nitrogen via 2 routes, by urine, which is a problem when you have kidney disease, or via the feces. And it's possible to increase the route via the feces. So we reduce the protein supply and we increase the fermentable carbohydrates. In the colon, the colonic bacteria can break things down by saccharolytic fermentation, which give us the good stuff like short-chain fatty acids and will reduce pH, or it can go by proteolytic fermentation, which give us the not-so-good stuff like the phenols and the indoles. In chronic kidney disease patients, they supplemented them with arabic gum, and they found a reduction in urea levels. This is two fairly old studies, and an increase in fecal nitrogen excretion. This is a very nice, more recent study that shows that the stool nitrogen, that's the darker bar, goes up when you give the fermentable carbohydrates. The urine goes down, but the total excretion of nitrogen is the same. So we force excretion via the gastrointestinal tract. There's also a whole lot of studies now, specifically on p-cresol, on how to reduce it. They've used oligofructose, inulin, pea flour, all of them have shown a benefit. And an additional benefit that's been seen is not only on the uremic toxin, but on stool frequency. We also know that the gut is leaky in chronic kidney disease, and fibers plays a very important role in gut integrity. Although most of our attempts up to now have been to reduce the intake of nitrogen to treat these uremic toxins, it seems that we now have another way of doing it as well. Important guidelines: increase your fiber as always gradually. And if someone shows intolerance, identify which food items it is and exclude it. Please still remember the potassium content. And that's just an article by Rossi et al. Recently published that also had a lot of guidelines. Other advantages of increasing fiber in the diet of kidney patients is that it helps with the excretion of cholesterol and reducing cardiovascular disease. And it also contains a lot of antioxidants, which give you less liver peroxidation. Then one of my favorite topics is the probiotics. And I promise I won't talk about the brain-gut interactions today too much. I think I've used this slide for the last 10 or 11 years. Probiotics will be the medicine of the 21st century, what antibiotics were to the 20th century. And the research now is absolutely amazing. There's absolutely amazing, very exciting stuff coming out, though they're not ready to be implemented. But for the first time now, I can start believing that this could be true. Just a reminder about what probiotics are. It's live microbial food supplements that upon ingestion in certain numbers have a beneficial effect on the host by improving microbial balance and exerting health benefits beyond the inherent general nutrition. And that's just a reminder slide again about where they are involved in the immune system and etc., etc. Quite interestingly, people who eat different diets have different microbiomes. So if I take a vegetarian and a vegan and a Tim Noakes patient, they will all have different probiotics, microflora. And what is also very interesting is that you can change it within 24 hours. That we didn't know before, that it can actually be that fast. So if you change, if you have a high protein animal fat diet, you will have a lot of bacteroides. If you have a high carbohydrate diet, you will have a lot of Prevotella. Chronic kidney disease results in a decrease in diversity and or referred to as a dysbiosis. What they did find is a decrease in certain families of Bacteroides and Firmicutes. There's especially a reduction in your Lactobacilli and Prevotella species, and an increase in aerobic and anaerobics in the duodenum, which is not supposed to be very heavily colonized in a normal person. Chronic kidney disease, patients on hemodialysis has been shown to have an overgrowth of aerobic bacteria. The total number or amount of bacteria is different. Enterobacteria and Enterococcus species is 100 times higher than in normal people, and significantly reduced numbers of bifidobacteria and higher number of Clostridium perfringens. So, the way their microbiome changed due to their kidney disease mean that they get enhanced proteolytic fermentation. So that all makes it worse and worse. So they have a dysbiosis. This slide just shows you why they develop this. Various things, from metabolic acidosis to things like oral iron, can contribute to your dysbiosis. And in addition to that, you have impaired protein assimilation in the gut. So a lot more protein rests will get to the colon. And that means that you will shift to proteolytic fermentation. The consequences thereof, you can clearly see on this slide the effect on the tight junctions and on inflammation and various other factors. Bottom line is we end up with a vicious circle. Urea and uremic toxins is high. Now we get more proteolytic fermentation. Now we get a dysbiosis, which means we get more proteolytic fermentation, which means we have more urea and uremic toxins, which means, so this thing will start running in a terrible circle. Is there a rescue? Is there something that we can do about it? And yes, if we start looking at probiotics that are specifically anti-inflammatory, it can improve a lot of problems like endothelial dysfunction and can stimulate leukocytes. And this is just all the organ systems where it could potentially have an effect because of the anti-inflammatory response that you will have. The impaired gut barrier in these patients mean that we have increased intestinal permeability with a lot of histological changes. There's a lot of urea, there's a concentrated urea in the body fluids, which will now go into the colon, heavily into your gut. Urea and urease processing bacteria will now make a lot of ammonia, which is caustic, which means it will burn the intestinal lining. Plus, you have subclinical inflammation, you have regional ischemia because of hemodialysis, and you've got venous congestion because of fluid overload, so no wonder the poor gut becomes leaky. So you get a dysfunctional barrier. From that, you get bacterial translocation and endoxemia, which will give you infection, which will give you systemic inflammation, and there another cycle is running. So if you drop the fiber intake, the effect on the intestinal bacteria will change, and you will get less short-chain fatty acids, who is important fuel for the colonic cells and to keep them healthy. And that's just a slide to show you. This one, you can see how tightly those cells are together. And in that one, look at the gaps and look what is happening with pathogens over there. They termed this interrelationship between the two as the kidney-gut axis, this circle that starts running. So what about Bunce's therapy? Can we start using probiotics? The idea is not new at all. Dios Cordelis in 2,000 years ago already said that we can do this. Pre and probiotics, there's a very good summary by Rossi in 2012, and she also did a meta-analysis that suggests that there is a benefit, but highlighted that the body of evidence is weak. She's busy with her PhD on this. I was looking, but the Synergy trial is not available yet. So pre and probiotics, we should consider them so that we can increase saccharolytic activity, get more beneficial products from that, decrease protein bind solutes, thus decrease inflammation, have a healthier gut wall, prevent bacterial translocation, and prevent further transport problems. And this is just a few studies that's been done. They're not big enough, I think. They're not in-depth enough, but there are some that already show you can reduce BUN, quality of life, and some of them started doing proper research with specific species in specific amounts. And every time it seems the larger amount may be more important. Though you can see there's some more studies and they look at various outcomes. Proposed mechanism is probably a reduction in colonic pH, decreased in colon transit time, and a decreased availability of substances. There's only one animal study I will show you, and it's this one, because I think it's an amazing study, where they compared normal versus CKD rats, and they also used amylopectin versus amylose, which is fermentable and non-fermentable starches. And the patients who got the non-fermentable one or got the placebo had this normal progression of kidney disease, while those that got the fiber didn't. And in addition to that, the fecal water content increased, which is great because you get rid of the fluid overload. You get, hopefully, a looser stool, and your patients with kidney failure often have constipation. So I think if we can replicate this study in humans, it will be amazing. And I'm almost done. The last thing, I think I'm going to be out of work soon if the probiotics work that well, but it seems that we can actually reduce phosphate by giving certain probiotics as well. And that's just a summary slide again to show you how interrelated they are. One last thought, would the Mediterranean diet be the best one here? Possibly. High in complex carbohydrates and fibers and vitamins, low in animal proteins and low in bad fats, generally will promote saccharolytic activity. So to conclude, we're going for a major paradigm shift. We're going to use diet to impact metabolism, to reduce kidney disease and the consequences like chronic cardiac diseases. We've now got a link between dysbiosis and consequences of kidney disease. And maybe in future we'll treat these patients with fiber, protein, and pre or probiotics. And thank you.